The oral switch in MSSA bacteremia, evidence and eligibility. The historical dogma that Staphylococcus aureus bacteremia mandates a full course of intravenous therapy is being challenged by emerging randomized evidence. While the standard of care for methicillin-susceptible S. aureus, or MSSA, remains high-dose IV beta-lactams, specifically cefazolin at 2 grams every 8 hours, or anti-staphylococcal penicillins like nafcillin, the Sabato trial has established a pathway for a safe transition to oral therapy in a highly selected, low-risk subset. The Sabato trial demonstrated that switching to oral antibiotics after 5 to 7 days of effective intravenous therapy was non-inferior to completing a full 14-day IV course. The primary composite endpoint, which included relapsing bacteremia and deep-seated infection, showed a treatment difference of only 0.7 percentage points. However, this non-inferiority is contingent upon a rigorous definition of low-risk status. According to the 2025 JAMA-directed therapy guidelines and the Sabato protocol, eligibility for an oral switch requires the absolute absence of a deep-seated focus or metastatic seeding. Patients must be hemodynamically stable without septic shock, achieve bacteriological sterilization within 72 hours, and remain afebrile for at least 48 hours. Furthermore, any implicated intravascular catheters must be removed, and patients with prosthetic heart valves, vascular grafts, or severe immunodeficiency must be excluded. When these strict criteria are met, the recommended first-line oral regimen for MSSA is high-dose trimethoprim sulfamethoxazole at 160/800 milligrams every 12 hours. Clindamycin remains a secondary alternative, while linezolid is reserved for methicillin-resistant strains. We must exercise extreme clinical caution. Only approximately 23% of all SAB patients qualify as low risk. Misclassification is a significant hazard. A premature switch in a patient with occult sequestration can lead to catastrophic treatment failure. For patients on active chemotherapy, a group largely excluded from the Sabato cohort, the threshold for an oral switch should be even higher, given the potential for impaired host defense mechanisms. In conclusion, while the POET and Sabato trials provide a robust framework for oral step-down, infectious disease consultation is essential to ensure that the patient's clinical trajectory and source control justify a departure from the intravenous standard. For the majority of complicated cases, the 4 to 6 week IV duration remains the non-negotiable benchmark for care. Take-home points for clinicians. The low-risk reality check. Only approximately 1 in 4 patients with SAB are actually candidates for an oral switch. If the patient has any hardware, persistent fevers, or community-acquired infection, they likely do not qualify. Sabato timing. The switch occurs after 5 to 7 days of IV therapy. It is not an oral start strategy. The chemotherapy caveat. The Sabato trial excluded severely immunosuppressed patients. For a patient on chemotherapy, the risk of occult complicated disease is higher. ID consultation is mandatory before considering an oral switch in this population. Oral agent selection. MSSA, TMP-SMX, is the data-driven first choice. But what about cephalexin or cefadroxil? Many clinicians would prefer those choices for sure. MRSA. Linezolid is the preferred switch agent due to its near 100% bioavailability. Failure of C-reactive protein. As noted in related sepsis literature, ADAPT sepsis, do not rely solely on inflammatory markers to decide on an oral switch. Clinical stability and repeat culture negativity are the hard endpoints required.